This is a young lady presenting with headache. An MRI brain was done for evaluation. So the diffusion weighted imaging sequence does not reveal any abnormal signal intensity. T2 flare images again do not demonstrate any abnormal signal intensity. T2 weighted images appear totally normal. T1 normal. Susceptibility weighted imaging is normal. Non-contrast 3D TOF angiography again is unremarkable. Now, this is only a 28-year-old patient, all right? So your brainstem, everything looks all right. So does the cerebellum. But if you look at the cella, you can see that the cella is partially empty. The pituitary appears to be flattened out towards the floor of the cella turcica. And in these sort of patients, when you have only certain subtle findings, like for example, most of the study is unremarkable, you have no positive findings, you need to have a look at when there is isolated findings like partial empty cella, prominent CSF volume in the cella turcica. Try to look at for example, the perioptic CSF space. So if you have other sequences which have been taken, maybe you can look at coronal sequence. If there is any bit of prominence or tortuosity of the optic nerves or a prominence of the perioptic CSF space, you should raise the possibility of idiopathic intracranial hypertension. So a partial empty cella in a young patient who presents with headache without any other imaging finding is probably one of the clues of idiopathic intracranial hypertension. So always look for what is the clinical presentation of the patient, and of course documenting any sort of raised intracranial pressure wouldn't require a lumbar puncture.